All right, we're going to dive into some topics on calcium. At the end of this, we're going to do some board review questions on calcium, parathyroid issues, some vitamin D stuff, some bone issues as well. I just want to remind you to please don't do this while you're driving or multitasking. To really get the most out of these virtual asynchronous lectures, I really encourage you to take notes. So sit down, get a piece of paper, pencil, and let's dive right in. We're going to start out with defining hypercalcemia based on severity. So we're going to call mild with the calcium level of 10.5 to 12, moderate calcium level of 12 to 14, and severe is when the calcium is greater than 14. A couple little tidbits here. If the patient has a calcium greater than 12 plus symptoms, you need to treat them. If a patient has greater than 14, they need urgent treatment. And when I say urgent, I mean inpatient or hospitalization for IV stuff, and we'll talk about what that stuff is. So treatment, number one, first line is IV fluids by way of normal saline. The function of this is to increase renal excretion. So literally flush it out. If that doesn't work, or they're in the critical situation, you can use Lasix, again, to increase renal excretion, and Bisphosphonates. If they're refractory, calcitonin. And if you've tried everything and it's all failed, dialysis, critical situations. A lot of times hypercalcemia goes with CKD and ESRD, so dialysis is sometimes used earlier on when it's because of end-stage renal disease. So most common causes of elevated calcium, most common causes of high calcium in the outpatient setting. Number one is primary hyperparathyroidism, and I'll use this abbreviation HPTH for hyperparathyroidism moving forward. Number two is cancer. In the inpatient setting, number one is cancer. So these patients tend to present with more of the severe elevation of calcium, and then they need that urgent inpatient treatment. All right, so I'm going to try and squeeze in the workup algorithm here for you. So we've got a patient, they've got a calcium greater than 10.5. How do we deal with that in the clinic? You don't need to refer these out right away. You can do some of this on your own. Number one, you need to correct the calcium. And we all know this calculation. You can find it on MD Calc, but you basically use the albumin to get a corrected calcium. Number two is you need to stop diuretics and recheck. Many diuretics can cause hypercalcemia, even in the moderate ranges. And then need to take a good history to evaluate for the multiple endocrine neoplasm syndromes, patient's Tums use / dietary stuff, GI problems that might cause absorption issues, vitamin D, so you'll use that to kind of guide you. So once you've done that, you can go ahead and check their parathyroid hormone. And again, don't be afraid to do this. We can do this as primary care docs. You're either going to get into a situation where they've got a low parathyroid hormone, or they've got normal / high. Both of these are worked up the same way. So we'll talk about low first. These are unlikely. This is unlikely test question, unlikely finding in clinic. But what are the causes of elevated calcium with a low PTH? Parathyroid hormone related peptide caused by cancer. Bone lysis, again, usually METs or cancer. In that situation, you'll want to check an alk phos, so that's part of your workup. And then there's adrenal issues like acromegaly, again, really rare. Super rare, but thyroid issues can cause a hypercalcemia with a low parathyroid. The thyroid is so dramatically impacted structurally it can cause damage to the parathyroid gland. So anyway, in these situations, again, they're unlikely, and what you're going to want to do is refer to endo in this situation. More likely, you're going to get a normal or a high parathyroid. Excuse me. The next step in that is going to be to check 24-hour urine calcium. Now that result's either going to be low or normal high. If they've got a low urine calcium, we're looking at familial hypocalciuric hypercalcemic syndrome. No treatment. Done. Just be careful if you're ever going to put this patient on a diuretic or calcium supplementation for osteopenia or something like that. If they've got a urine calcium that is normal or high, now we're looking at either primary or tertiary hyperparathyroidism. In that situation, your next step is to consider surgery versus meds. And if surgery, you need a cystoscopy scan. All right. Now, let's talk about the causes of primary, secondary, and tertiary hyperparathyroidism. So primary, 85% of these cases are an adenoma of one parathyroid gland. The remaining 15% are one of the men's syndromes, parathyroid cancer, multiple adenomas, and then neck radiation. Neck radiation can trigger the parathyroid gland to produce parathyroid hormone. Radiation. Okay. Causes of secondary hyperparathyroidism. Come down here. Low calcium triggers the parathyroid gland to release parathyroid hormone. So that's why it's secondary. Primary is like the parathyroid gland is just doing extra of its normal job because it's got an adenoma or a tumor or something. Secondary is low calcium triggers the parathyroid hormone to do more than its normal job. Or actually, I'm sorry, to do its normal job. This is usually earlier stages of CKD that cause low vitamin D because the kidney transforms vitamin D25 into 125 hydroxy vitamin D. Low vitamin D means low calcium absorption, which means increased parathyroid hormone. Another cause could be a low calcium or vitamin D intake. And because the calcium levels are low because you're not getting it in your diet because you've got a malabsorption, or your vitamin D levels are low because you live in northern Michigan, that all triggers low calcium, which then triggers the parathyroid gland to make more hormone. So another example of this low calcium or vitamin D state would be like a malabsorption problem. All right, so what is tertiary hyperparathyroidism? It's basically secondary hyperparathyroidism gone totally unchecked. So this is prolonged hypocalcemia, stimulates the parathyroid gland and causes a hyperplastic gland. And this is usually due to prolonged CKD or worsening CKD. So you could have a patient with CKD, have secondary hyperparathyroidism. Over many, many years, eventually the parathyroid gland bulks up to try and compensate for the low calcium, and in that situation, it can become hyperplastic, produce more parathyroid hormone, and then you get an acute hypercalcemia problem. Just going to give you a little pictorial guide of this whole pathogenesis. There was a board question on this 2 years ago. So here's our thyroid gland, here's our parathyroid glands. Let's say someone's got a single adenoma and one enlarged parathyroid gland. Now that parathyroid gland, that adenoma is active, it's producing parathyroid hormone. This functions at multiple levels of the body. 1, it causes bone reabsorption of calcium. 2, these are my kidneys here. It causes increased calcium reabsorption at the kidneys. It causes increased conversion of vitamin D25 to 125 vitamin D. Sorry, I meant to say 25 vitamin D. And then lastly, it works at the level of the gut. Not a great gut, but there it is. To increase calcium absorption. The elevated vitamin D from the kidney will also contribute to increased calcium reabsorption. And all of these things cause high calcium. All right, so that's the pathogenesis of primary hyperparathyroidism from, in this example, one adenoma. All right, so when do we do surgery on that one adenoma? Number 1, patients with symptoms. And those are favorite test questions: stones, bones, as in like pain, and thinning bones, like osteoporosis, groans, bones, and that's GI problems. So patients who have symptoms, you're going to treat. What about patients without symptoms, but have other things? Low GFR, like as in they have CKD. Calcium greater than 1, the upper limit. Urinary calcium excretion greater than 400 mgs in 24 hours. So like kidneys are working overtime to get rid of all that extra calcium you have. Low bone mineral density, like osteoporosis. Age under 50, and we'll talk about why. And of course, our favorite, patient preference. If someone's not going to have surgery, how do you monitor this? They get a biannual calcium, an annual creatinine, and an annual DEXA. I would probably check the creatinine twice a year clinically, but technically this is all you need to do. Unfortunately, 25% of observed cases, like cases that you decide just to wait and watch and monitor, 25% of those need surgery anyway. And that's kind of why there's this age under 50. Chances are with time that the adenoma is going to get big enough to need surgery before the patient would have another illness anyway. And since it is a head and neck surgery, it's better to just take care of it when someone's young and better able to tolerate the surgery, because chances are someone who starts with this at the age under 50 is most likely going to need surgery anyway. A couple things about vitamin D, because these came up on the test in training exam. Testing levels. What test do we want? 25 hydroxy vitamin D. In rare instances, 125 hydroxy vitamin D if they have like end-stage renal disease, a really bad CKD. I've never checked those myself. I think that would probably be up to nephro. Treatment options, we have a few. There's vitamin D3, which is over the counter, and then vitamin D2, which is a prescription that comes in 50,000 units per week. And another little tidbit for you, a vitamin D level less than 12 cannot support bone health. So you're going to end up with osteopenia or porosis if you have a consistent vitamin D less than 12. I want to tell you a few things about Paget's disease because it's highly testable. So what are the stages? Number 1, you get bone reabsorption of calcium. Number 2, you get woven bone production without proper mineralization. And as a result, you get dense, crappy, irregular, sclerotic bone formations. Symptoms, because of these cruddy structures, you get soft tissue and nerve compression. And again, that's because this dense, crappy, irregular bone can compress soft tissues nearby it. That can cause pain. It can cause osteoarthritis. It can cause kidney stones. So diagnosis and workup, really you're going to go based on symptoms. You're going to get an x-ray to look for those bony formations. You're going to get a family history. You're going to get an ALK-Phos level. This will be elevated. And you're going to get a bone scan. That'll show this clearly. Treatment, bisphosphonates. Okay, that's all you need to know about Paget's disease. All right, a few words on osteoporosis. Routine screening per the Uspstf, women greater than 65 years old. Clinically, you might do this earlier in someone who has more risk factors or went through early menopause, but Uspstf says women under 65. So let's talk about what we're looking at on this bone density we're using to screen. We're looking at the T-score between 0 and -1 is normal. Between -1 and -2.5 is considered osteopenia. And less than -2.5 is considered osteoporosis. Severe osteoporosis really just equals someone who's had a fracture plus osteoporosis. All right, let's talk quickly about treatment indications in osteoporosis. Number 1 is simple. If they have osteoporosis, you treat them. So a T-score greater or less than or equal to -2.5. If they don't have osteoporosis, but you use something called the FRAX calculator and you get 10-year hip fracture risk greater than or equal to 3%, you can treat. If you do that FRAX calculator and you get a 10-year major, not just hip fracture risk greater than or equal to 20%, you just treat them. And anyone with a previous hip fracture, you just treat. And what are your treatment options? Bisphosphonates. And or Prolia which is denosumab. I'm not going to write this down, but you should if you don't know it already. Bisphosphonates include alendronate and resendronate and zoledronic acid, which is called reclass, and it's an IV bisphosphonate. So keep that in mind for patients who can't tolerate the oral stuff because of GI symptoms. And then again, Prolia is denosumab. So in 2017, the American College of Physicians put out some guidelines on treating osteoporosis, and we're going to talk about the major takeaways from that initiative. Number one are the treatment options, which we just talked about. So just reference our previous slide. Number two takeaway is that treat women times 5 years. Number three is if you're going to treat a man with osteoporosis, use bisphosphonates, so not Prolia. It hasn't been studied in men yet. And again, we're not routinely screening men, but if you discovered a man with osteoporosis, you would treat with bisphosphonate, not Prolia. Number four, do not repeat that DEXA scan during the 5-year treatment period, unless you have another reason to look. It's not going to change your management. You're going to keep them on it for 5 years. Number five, do not use hormone replacement therapy or raloxifene to treat. This was popular. And it was part of the standard of care previously. Number six is use your favorite thing, shared decision making, to treat women with just osteopenia. So another fun discussion to have with our patients. All right, last few things. What are the men's syndromes? This is purely because you might get tested on it. But also so you know if you're seeing someone with high calcium, you need to take that good history. So men 1 is parathyroid adenomas, pancreatic cancer, and pituitary tumors. Most commonly prolactinoma. Men 2 is parathyroid adenoma again, or adenomas, pheochromocytoma, and medullary thyroid cancer. Very, very popular test question. Do not use which diabetic medicine in patients with a family history of one of these multiple endocrine neoplasm syndromes? The answer is a GLP-1 antagonist. So do not use those. They increase rates of cancer. All right, let's look at some questions. I'm going to just dive into the answer. So when you get to each question, pause the video, write down your answer, and then press play to hear the result. In this situation, the most appropriate initial management is IV normal saline. We talked about that being the first line of defense. Lasix would be second line. You could use calcitonin as well. Bisphosphonates would be in second line with Lasix. And then lastly, your E option, if all this fails, would be dialysis. Question number 2, the answer is to repeat the BMP with calcium. Remember, our first order of business is to take a good history, correct the calcium, and then stop any diuretics and recheck the level. So patient stopped her hydrochlorothiazide, and now we need to repeat the BMP. If we did that and it was still high, the next thing we would do is the parathyroid test. Based on that result, then we would decide if we're going to do parathyroid hormone-related peptide. These pieces would really come once we're looking at someone with CKD. The urine calcium and creatinine we would check after we got that parathyroid and we started thinking about other causes. And then the cystoscopy scan, you're only doing if surgery. And we talked about the indications for surgery. And a low vitamin D level is not an indication for surgery. If the patient really wants surgery, you're going to do it. If they're under 50 years old, you're going to do it. If they start having symptoms or end organ damage, you're going to do it. We talked about this one. If the kidneys are working overtime to keep the calcium normal, we're going to do surgery. And if it already got CKD, it's time to do surgery. The answer here is B, primary hyperparathyroidism. So if we go back to our algorithm, we start out with this. Patient's got high calcium. Even if we correct it, it's still considered high. She takes no medicine, so there's nothing to stop and recheck. You take your proper history, whatever. Then you do your parathyroid hormone level, and it's normal. And remember, there were two branches on that algorithm. One is your parathyroid hormone's low, and the other is it's either high or normal. So in this case, it's normal, so we're going to proceed with the 24-hour urine calcium. In this situation, also normal, so that rules out familial hypocalciuric hypercalcemia. And now we're down to it either being primary hyperparathyroidism or tertiary. This patient doesn't have CKD, and tertiary is not an option, so the answer is primary. The algorithm would have given you the answer in that one. All right, the answer here is 25 vitamin D. When you're just checking a regular old vitamin D level in clinic, you're going to get 25, oops, I forgot to put in here, hydroxy vitamin D. The only time you'd want to check a 125 hydroxy vitamin D is if they have CKD and you want to know if you giving them vitamin D is working, if the patient's able to convert that in their kidneys. So the answer is 25 hydroxy vitamin D. The answer here is vitamin D3. So I wanted to keep this question in here because it's actually a great example of why it's important to do multiple years of the in-training exam. This was a 2018 question, and the answer was vitamin D3. If you read up on AAFP, their most recent recommendations are actually for the patient to take vitamin D2, or ergocalciferol. But then they released another statement stating that there are different ways to treat vitamin D deficiency, and that using vitamin D3 at 2,000 IU, I think it was 2,000 IUs a day, could be good at maintaining normal vitamin D levels. In this instance, the patient has low vitamin D levels, so still based on that, the answer might be vitamin D2, or the prescription 50,000 units weekly. So it's important if you're doing the AAFP questions or the World In Training Exam questions, when you look in the answer booklet at the end, it'll reference where they got that from. And you should read, if there's ever a question that you got wrong and you're not sure about, read the article, see the year on it, and see if there's been a recent release of that same topic, especially if you get dipping into like the 2019 and earlier in training exams. So you can give yourself a pass if you put either A or C on this one. This answer, I don't know if there's any great way to know this one, but the answer is phenytoin. It has a side effect of vitaminosis D. Nothing to do but memorize that one. The answer here is C. Due to that bony, cruddy formation that we talked about from extra matrix of bone without proper mineralization that causes soft tissue compression and nerve compression. It can cause compression to the cranial nerve, causing hearing loss, unilateral hearing loss. This is part of the reason why when someone has unilateral hearing loss, you get an MRI. If it's bilateral, you can do the hearing test first. The answer here is a bone mineral density test. In this instance, we're looking at a patient who's at high risk of osteoporosis and osteopenia, which is very common in young girls with an eating disorder, anorexia. Cardiac workup you might have considered. Giveaway today is that we're not talking about that, but the cardiac workup is really only if they have a family history. So that's why the answer is bone mineral density. Her behaviors themselves, her condition itself puts her at high risk for osteoporosis. If she had a family history, that would put her at high risk for cardiac problem like hypertrophic cardiomegaly. Answer here is A. The Uspstf has got nothing to say about men and bone density scan. The only thing they say is if you're going to treat a man who's got osteoporosis, use bisphosphonate, do not use Prolia. The answer here is A. Calcium and vitamin D supplementation is indicated in osteopenia. You can use that shared decision making we talked about to decide if you're going to treat the patient, but in that instance, the only option that you might consider is alendronate. Estrogen, calcitonin would not be appropriate treatments. The repeat DEXA scan in 2 years and initiation of osteoporosis treatment, remember, you don't need to repeat it, and you're going to treat for 5 years, so that's why that one's wrong. And then alendronate, if you did use some shared decision making in a patient with osteopenia, you might consider alendronate. And then in this instance, even though she does have osteopenia, they go ahead and give you her Frax calculator score, so she still has a low hip fracture risk. So she could just be treated with calcium and vitamin D supplementation, and these are the recommended quantities. You don't need to supplement this whole amount. You just need to make sure that their diet includes this amount of calcium and vitamin D, and if not, then you supplement to meet the difference. And again, look at this was 2016 question. I honestly wonder if they redid this question after the 2017 ACP guidelines, B would not be an option. Because if you use shared decision making in this patient, you might consider bisphosphonates. So again, look at the year you're doing your in-training exam, look at the answers, and see what they're referencing. And these are all the, I thought I had one more question. Oh yeah, here it is. In this instance, the answer is the bisphosphonate, alendronate once weekly. Remember, raloxifene is not an indicated treatment. Teriparatide, not an indicated treatment. This is kind of tricky. Ranitidine's okay, but if it was a PPI, you would definitely consider stopping. So those increase your risk for osteoporosis. This patient had a hip fracture, so remember, anyone with a hip fracture should just go ahead and get on treatment, and so that's why this patient's going to be treated with a bisphosphonate, 70 mg per week. An alternative answer could have been Prolia. All right, if you want to pause here and read a little bit more about the reason behind the answers, at least per the in-training exam, you can look at that. But that is all, folks. If you have any questions, let me know.